all of this has been prepared by Karen and Rana, who is actually the executive co-chair, and I hope I pressed the right button. Okay, so in the last few years, the committee's been very active, and one of the things we've been doing is working on pectus, and as you can see, there is a lot of activity and a lot of input from a lot of different people. I'm actually supposed to be talking on this as the next talk, so I'll just move on from that because I'll be referring to it. Sorry, I'm going to have a look at it this way. Okay, so this is pectus. Another important area is looking at other aspects of thoracic surgery practice. So we are looking at new technologies, and we've recently had increased experience of implants to fill defects and close defects and do both more cosmetic procedures, but also major resections. There's a lot of interest in the use of endobronchial valves and using that as part of the management of hyperinflation. And about 2 years ago, we rolled out a process of making a model pathway for all patients with hyperinflation to be treated in an MDT format, so that all centres would provide both surgery and bronchoscopic valve therapy in appropriate patients. And that is work in progress, but we've gone from a situation whereby we had a non-commissioned service to a commissioned service and then a national rollout within quite a rapid period of time. I think that one of the consequences of that and the ability for us to be able to work collaboratively in the different SCTS units, which in the different countries, all of which have quite different ways of practice, has laid a good foundation for us in some of the things that we're trying to do. I think a very exciting area within our work has been the development of neoadjuvant treatments for the treatment of lung cancer. And a recently published study on nivolumab has shown that it is efficacious in surgically treatable cancers with an improved survival if given in the neoadjuvant setting. And this is going to produce a very big practice change in that there has been recommendations from NICE that all patients who meet the criteria, which is essentially a tumour of 4 centimetres or bigger and an appropriate molecular profile or relatively limited nodal disease, should be offered that if surgically resectable by other means. And that is a remarkable change because although the modelling is difficult to interpret and it's early days yet, but we're going to see tens of percentage of our patients who would originally have gone directly for surgery, or a smaller number who would have been inoperable, now going down a neoadjuvant pathway with what appears to be highly significant improvements in survival. And this will produce a practice change through all thoracic surgery units, which will ultimately lead to two things. One, an increased volume of work, which comes on top of the increased volume that's coming from lung cancer screening, and also operating in a slightly different way, because some of these patients will have had neoadjuvant treatment, and we'll have to understand exactly how that works out. To what extent will that be more challenging or less challenging as experience develops? In terms of evaluating outcomes, there is a project that is being run with multiple stakeholders with significant input from the Royal College of Surgeons and national organisations, and that is the National Consultant Information Portal, which provides unit level data on particular outcome measures, and many surgical specialties are involved with this. Within thoracic surgery, some of the outcome measures will be readmission rates, mortality, rates of post-operative renal impairment, and a few others. And the aim for that is that not only will people be able to see their performance, but they'll be able to understand where they are in a national context. An advantage is that it'll be not quite real time, but updated monthly. A disadvantage is that it's going to be based around HES data, which has got a lot of pitfalls in it. Now, this is still work in process, and there are a few pilot sites within thoracic surgery, and it will be some time before this is rolled out. The other our work streams are that we have essentially an oncology work stream, which is looking at, for example, thymoma, lung cancer, and other innovative treatments. We have recently created guidelines for GIRFT on the management of pneumothorax, airway obstruction, empyema is in progress, and tracheostomy is in process. There's ongoing efforts with the management of audit. A very important piece of work that we are doing, which is progressing relatively slowly, I'd have to say. And I say that because I've got quite a bit of responsibility for that. But it's tied up with the way that we're working with NHS England, is to review our thoracic surgery service specification. And I'll mention briefly why we need to do that. We're engaging as much as we can with other stakeholder groups, and Babu's spoken about the importance of patient participation. We're also involved with Task Force for Lung Health and the UK Lung Cancer Coalition. I'd like to just highlight again the meeting with the anaesthetists on the 6th of November, and I'll come back to that in my next talk. As you can see, Great Britain and Ireland has been instrumental in developing trials in mesothelioma and minimally invasive surgery for lung cancer, the Violet study, which have been presented in major plenary sessions at World Lung. Now, I have to mention and acknowledge that Eric Lim is the chief investigator for those studies. And we, as SCTS, are also supporting the UK and Ireland, well, the UK bid to host the European Society for Thoracic Surgery meeting in Edinburgh in a couple of years' time. I'd just like to go back briefly to the service specification and why I think that's really, really important. I'm so pleased that this work is going to carry on. Almost every problem that I hear of from NHS England, and many problems that I hear from amongst our own community and patients, they are actually related to the organisation and delivery of care. And rather than put a sticking plaster here, there, or everywhere, I think we have the opportunity, if we work well with our partners in our national healthcare administration. So in this country, NHS England, in Ireland, it's something else, in Scotland, it's something else, and so on. We can actually design it so that not only is it a good pathway that is effective, and you've heard about the importance of that in TAVI, but also it delivers what our patients need, because nobody else at all really knows what is required. So we'll continue to work on that, but to do that, it requires building alliances and trust and alignment with those healthcare organisations, and that is work in progress. We're working together as closely as we can, recognising the differences between our different countries. Thank you.
Thank you. So, this may come up later on, but I might just pitch the question up now. This is about workforce planning for thoracic surgery in light of targeted lung health checks being rolled out across the UK. So obviously the initial cohort of pilot was for around 1 million who are susceptible. Will expand to 6 million. over the next 5-7 years, and delivery plans are going in. Of that, we will probably see an extra 50,000 lung cancer operations over the next 7 years, which basically doubles the amount of lung cancer resections we're doing in this country. So what is the strategy of SCTS in providing the workforce for this?
So I think it's a really, really important question. The 100% increase in volume, I have to admit that's higher than our estimates. Our estimates, which are based on the Manchester modelling, and please do, we need to know if it's dramatically wrong, is about a 30 to 40% increase in activity. But let's take it as a big increase, whatever it is. So within, I'll answer from the NHS England point of view. Okay, it's a focus of a great deal of discussion. Within specialised commissioning, we have 80 different disease areas that we're looking after, and so getting prioritisation has its challenges. But despite that, there's a recognition for that, and it's work in progress. But it's more than just increasing the numbers, because it's also about the capacity of the units, and it's also about the organisation of what we do. And the one approach to this is that we actually need to have surgeons and units doing more thoracic surgery more efficiently. So the questions that are being asked, and they're challenging questions, and I'm throwing it out there, is what would it be like if units, not individuals, units were doing 6-day working? What if it was standardly a long operating day? What are the resource implications of that, bearing in mind that a consultant job plan might be based around, at most, about 2 operating days per week? I mean, there are some who do more than that, but it's between 1 to 2. And within that, how do we use our plants? And will we be going to a virtual ward model and very accelerated recovery? And there is a project within NHS England, which is, we're not talking about more widely, which is titled Veritas. And that stands for Very Enhanced Recovery in Thoracic Anaesthesia and Surgery. And so that is a concept model. It is, at the moment, a lot of stakeholder engagement, a lot of quiet pilot studies going on. And it feeds into the November meeting with the anaesthetists as well. So I found that putting the feelers out there, putting the groundwork out there, and getting the organisation, NHS England in my case, to actually deal with that at a service specification level, rather than, Babu, you need 5 more surgeons, go and do it. And then, you've got no operating time, you've got no theatres, et cetera, et cetera. That's not going to work. So that's the approach that we're taking. And we're cognizant of the time scale, and we're just trying to stay, on that curve.
No, it is a very difficult problem. And I think, as you said, it's got to be at the system level that the changes need to happen. Yeah. And giving individual units support in the sorts of types of areas would be good. But one area you've not mentioned is increasing training numbers in thoracic surgery. I don't know if that's going to come up later on, but
Tim, we have got plans on that, but Tim will be best on.
Yeah.
Thanks a lot, Tim Jones, SAC Chair. Yeah, I welcome the discussion because this is something that lands in my email box and pretty much every meeting I go to as to what should we be doing about this. Now, we obviously can recruit a set number of trainees every year on ST1 run through, and those of you will know now that our first phase, the first 3 years of training is a common training, and then the second 2 phases, the next 4 years of training, we're going over to specialty specific training, so trainees that elect to go down a thoracic pathway or a cardiac pathway. Now, in response to the work that's already Naman's alluded to, we have what we've done called activating ST4 entry. Now, this is an exceptional thing, and we've had to go through a lot of provision to get this in place. So what this means is that instead of moving to a model of pure run-through training that people start at ST1 and come out at the end at certification, we've turned on another access point at ST4. Now, the reason for ST4 is because this is when trainees actually declare their specialty interest. We're coming in for a lot of criticism by the Confederation of Postgraduate Schools of Surgery and also by some of the other educational groups that we're setting up perhaps a two-tier system that could be advantaging or disadvantaging certain groups. So we're trying to work through that. But the current situation is we've turned on ST4. We need to know how long we need to keep this running for. It's been running for 2 years so far, and we've recruited 4 additional people at each of the 2 years. This is on top of ST1 run-through. We haven't dropped the numbers on ST1 run-through. So these are extra specific trainees in pure thoracic surgery. We went out for an advert of 6 last time and 4 meta-standard who we felt should enter a training program. Now, if we run this for the next 3 to 5 years and we recruit, say, up to 6 per year, and we've got 3 more years of this going, you could imagine we'd be putting 25 to 30 additional trainees into what we're thinking can be supported by units. Now, this is a really dangerous place for us to be in because, as Alan's already alluded to, the NHS employers need to create posts for those trainees. And I can't keep on adding trainees into the system not knowing that they're going to be an expansion in consultant posts. So I'd ask all of you in your units to identify, are you expanding consultant posts and where? And please feed that back to us, because we've already got the first 2 years have gone into training. We're talking about a 4-year training program. So in 2 years' time, additional trainees will be coming out. And for the next 3 to 5 years, you'll be having up to 6 additional trainees each year to be housed in jobs in the United Kingdom. Now, we have been notoriously bad at allocating trainee numbers at completion of certification to existing posts, and I am fearful that we will potentially end up with 24 thoracic trained individuals and the unit saying, we'd love to have expanded those posts, but we just haven't got the theatre time, the clinic time, the secretarial support. So please, if your units are not expanding numbers and not planning to expand, because if you are planning to expand a number for 2 years' time, you should be doing that at the moment. We know how long it takes to get additional jobs through the NHS. So if you're not doing that, or if you are doing it, please let us know, because we're slightly going in the dark here, but we are increasing those numbers.
Can I just reiterate those points? That workforce planning is one thing, but the infrastructure and the service specification around it is the most important thing. We know the numbers are going to expand, but we've got to have the infrastructure and the units to develop that. We've talked about elective cardiac surgery waiting time, so there's got to be a push somewhere to create the theatre time to allow these patients to be operated on, and that needs to happen both not only at an NHS level but also at a trust level, because they've got to identify their population needs from that. So it's a multi-pronged approach, but it's a big issue.
Eustace Fontaine from Manchester. Babu, you're not too far off actually in terms of the prediction for 4 or 5 years, and we probably will do an extra 150 to 200 resections in the next year, and we got 7 surgeons based on just one patch of Manchester, and that's a sort of a Tameside patch, and we'll probably go up to 8 probably from the start of next year based on lung cancer screening. And we're getting more sessions, but the rate limiting step in terms of the infrastructure is the theatre staff, the scrub staff, and that's a huge problem, such that we have to recruit from overseas. So, and we'll need more ST4 trainees, because, as Bible says, probably in the 4 or 5 years we'll double in terms of what we're doing now, and then there'll probably be a slight decrease. So it is a huge undertaking to try and get the manpower to deliver these operations.
This is yeah. So Tim, the number that workforce modelling was, you know, that there was quite a lot of work that went into that, and we were asked to go conservative. And I don't have it in front of me, but the prediction was within 5 to 10 years we would need 30 new additional consultants at ballpark, to account for predicted retirements. And there may be fewer of those because people are delaying the retirement because of pension changes and so on, but an increased workload. But it was modelled on at the 30% increase in activity. So if we're already beginning to see much more than that, then that is really important to know. And it's actually based on the Manchester figures. Yeah. Sorry, there is a... Sorry.
Hi, Ashok Kar, Northern General. I appreciate all the work that's being done in terms of the service specification, but, you know, you're talking about in cardiac surgery, SABR versus TAVI, and the increased workload. We could be in a similar situation with early stage lung cancer with SABR being offered by NHS England rather than surgery, unless we address the issue soon, because we will, you know, patients will have that option given to them without our choice or input, potentially.
Well, I think we should talk more about it outside, but I don't know how it will happen without our choice and input. You know, let's talk about it.
Sorry, just one other point. It's a plea to everyone in the room who are involved with training. We've now also got ISCP to put a new thing on the ISCP web pages, where trainees, once they've decided what part of the specialty they're going to go into, they should now detail this. And this is because we've got no central data or way of capturing of our overall population of trainees who wants to go into thoracic, who wants to go into cardiac. So please, it's an optional field, but please can you ask and ensure when you're talking to trainees that data is inputted, because this will help inform the workforce and give us more of an idea that we can then multiply over the next 4 to 7 years. Thank you.
Thank you.
Just got one further crazy idea, and I'll probably be shot down for this, but I was going to say it anyway. I understand there are a number of unemployed cardiac surgery trainees, and of course they are trained in thoracic surgery earlier in their years. Is there a role in some of those to offer some of those people a way to transition to the dark side with a shortened training program?
I've been given a microphone. I should be given a gun. Right. We don't have any unemployed trainees currently. They're all in various posts, either gaining some specialty interests. We don't have people who've come to a situation and are saying that, you know, that they are without employment and without further specialization. So we historically, if you look, that's what I should say. The chances that they solve the problem are limited. Their country progressions. There are people being appointed, and the system is moving through. There was a big concern that we were going to have probably a third of our trainees and not in appointed posts. That hasn't come out. The biggest problem with workforce, and we've seen this historically, we've over-recruited and we've under-recruited, and we go on this sort of, you know, wave, and the line runs somewhere through the middle. And what we do is the system accommodates. Now we are accommodating, and there is flex in that. The biggest concern that we have going forward is obviously uncharted territory of trainees specialising very early on now, plus also adding in an ST4 entry. It makes it very difficult to do the workforce calculations. But no, there's been a lot of concern that people are sitting unemployed. They're currently not. And I know I was one of the people who was driving some of that work, because I thought there would be a big bulge. The bulge is being spread out, and people are now using subspecialization, and also the work that Elizabeth's been doing, looking at post-CCT fellowship posts as well, giving people further subspecialization in cardiac.
Thank you. In the interest of time, we'll move on to Aman's second presentation on Pexus Care and where we are today.
Okay, is that better sound, Emma? Yeah, okay. You want me to... It's by my groin. Okay. Okay, all right, thank you. Yeah, just before I go to this presentation that I actually know something about, I would just like to say that within NHS England, we don't want to close any thoracic surgery units, but it's also recognised that in the last 15, 20 years, we've lost about 10 thoracic surgery units, which have, and the work has gone elsewhere. If we set this standard for the specification so that every unit has a robot, every unit has 6 days a week operating, and so on, every unit has navigational bronchoscopy, we will very rapidly end up with a situation whereby we need larger units, which will mean we have fewer units. And I think we all need to just be aware of that there could be some rationalization, but we don't want to close any unit. So I think that, you know, if you've got good regional collaborations, if you can think about ways of consolidating, it will be fantastic if people could have that in their mindsets.